thank you for the opportunity to speak today. I'm mindful I'm the first real-life person in the room. I also very much appreciate the fact that surgeons have been inviting physicians to meetings now for a while, but I'm not sure that we've quite got around to replicating the invites. So I think that we as physicians probably still have some way to go. I thought at first my talk might be a little bit controversial, but having heard the last two, I think we're actually all on the same page. And I think the challenge for all of us in healthcare is how do we move forward, and because I think the patients are getting beyond the scope of any one of us being able to manage them because of the complexity of what we're caring for. Because the cardiologists have got too good at stenting, and that means no one's dying of heart attacks anymore, so they're dying of all of the consequences thereof. I took this slide, like I liked the quote because obviously it's from Jurassic Park, where Jeff Goldblum's character asks the scientists, you're so preoccupied about whether you could, you didn't stop to think if you should. And I think that that applies as much to me as a physician as it might do to you as a surgeon. So obviously, as a physician, I have my own inherent biases. We all come with our own biases. So I think I should be open about that to start with. So unless you're a pediatric surgeon, and I don't know how many of you are pediatric surgeons, half of your patients are old, and half of your patients, they're much more likely to undergo emergency surgery if they're going through the public system. I know in Australia, a lot of the private system looks after a lot of people electively. So I think if we're going to move forward with how we look after older people, we have to kind of collectively take our heads out of the sand and go, it's someone else's problem. Oh, this patient, they're not my usual patient, they kind of are. And we have to figure out a way of moving forward together rather than kind of working in the silos that we have. I don't think this will be surprising to anyone, although I certainly, before I started perioperative medicine, I had no idea there were 2 peaks to appendicitis. I still can't believe that lap choles aren't on here because my goodness, Logan is lap chole central. And then if we look at elective surgery, so the biggest increase in elective surgery is 10% year on year is people aged 85 and older. So if we're moving to a point where we estimate now that by about 2050, half of all surgical procedures will be performed on people aged 65 and older, which will be me in 2050. So, you know, we all hope to get to the older age. So I suppose when I see people being referred to me because I work both with acute surgery and with elective surgery, most of the decisions around surgery for older people are life prolongation or quality of life decisions. It's obviously elective versus emergency, and then within each procedure you've got choices around the procedure you make. So for example, with a colon cancer you might decide to resect versus a decision to just put in a diverting stoma. So I think if we just take the life prolongation, I certainly think that for the majority of people that are offered surgery, surgery does prolong their lives. But there are caveats, and I think this actually comes to Dr. Crozier's first case where he was talking about the man in the nursing home. There's a lot of, it's very hard to get good data on mortality and longer term mortality in older people. And I think when you look at some of the stuff around nursing home patients, people in nursing homes are not there because they're fit and well. People are in nursing homes because they can't get out of bed, they can't get to the toilet themselves, they can't run a household, and that exceeds the amount of care that it can even be provided as part of a community care package. In each of these groups, the mortality at a year was 50%. Now, some of that may be accelerated mortality with surgery, but actually you're probably getting people who are already on the slide down, and then you're doing a procedure in someone where it's actually not going to make any difference to their life expectancy. And in that vascular surgical study, there was 50% were dead in a year, and of those that were alive, 80% of them were immobile. So it doesn't do anything to prolong life, nor does it necessarily do anything to improve one's quality of life. And even breast cancer surgery, like breast cancer surgery is probably some of the least physiological challenging surgery that you can undergo, 40% mortality at 1 year. Again, showing it's probably not the surgery, it's about the patients that you're picking for the procedure. I think we're well aware of a lot of the mortality issues around emergency laparotomy. And if you look at those who are older, their mortality rate is substantially higher than younger patients. And if you add in a frailty score, that increases again. So just before kind of moving on from that, I do want you to think a little bit about so we know older people have higher mortality rates, but do we actually set them up to fail? And by that, I mean, the data from, this is from Jenny's paper, suggests that older people are less likely to go back to theatre, they're less likely to have an intensive care admission to start with, and less likely to return to intensive care. Now, some of those decisions are probably quite reasonable, but if you're going to do an emergency laparotomy on someone, and the ANZILA data and ANZILA recommendations are they should go to intensive care afterwards, you should follow through and not just go, oh, they're a bit older, there's no point in going to intensive care. So I think we do need a little bit of a stop and think, if you're going to go and do something, where are you going to stop doing something, and where are the appropriate touch points where those decisions need to be made. And I think some of this was borne out as well in how we look after older people with that report from the UK that I think many of you will be familiar with, which actually probably led to NELA. So we often talk about morbidity and mortality, but and one of the issues I have when I read surgical literature as a geriatrician, and really, to be honest, physicians are actually no better at this, is that we talk about things in terms of length of stay and morbidity and mortality. Now, for a lot of our patients, they might have a non-STEMI with a troponin, which previously would not have been detected, of like 100 versus, certainly the high sensitivity troponins of 100 is actually not that high. But it might not change their outcome. But we actually don't talk a lot about what are the functional outcomes of that, and what are the quality of life outcomes for people who are undergoing surgery. Okay. There we go. So these are just a couple of papers which have looked at quality of life in older people, and I think one of the challenges I found in trying to read things around quality of life is that functional status and quality of life are often used interchangeably, and there's no doubt that good function is often associated with good quality of life, but the two are not interchangeably used, and that's some of the challenges in the surgical literature. But when you look at, you know, that study on the quality of life in octogenarians, about 20% of them had absolutely no change in their quality of life. And that's of those that were alive. Only 60% of them were alive at a year. And then the one with hip and knee surgery and knee arthroplasty, again, like about 20-25% had a decrease in their quality of life a year after surgery. What's interestingly is the colorectal surgery paper kind of goes against that a little bit, and people who had colorectal surgery, even if they were frail, felt that their quality of life had improved. And maybe it's that they felt that, well, their cancer was treated. So I think it's not quite black and white. No. Nope. Okay. Obviously, most surgery that's done in most places is elective, and there does seem to be a bit of a difference between elective quality of life outcomes and emergency quality of life outcomes, and I think that that's probably just an important thing to think about when talking to patients about, you know, in emergency surgery, you're more likely to actually have a poor quality of life. And when you look at those in emergency laparotomy, the older patients have a much poorer quality of life when it's measured versus the general population. So if we take the quality of life and then separate out the functional side of things, and I said the two are often combined, but function is one of the things that when I'm looking at people preoperatively, they tell me is one of the most important things to them. One of the things I constantly see, especially in the joint patients, I don't know what it is about orthopedic surgical patients, but every man and his dog has had a joint replacement, and they've normally had this amazing outcome. But the person I'm seeing has got 400 comorbidities, doesn't get out of a wheelchair, and thinks that they're going to have the same outcome. And patients, like in the literature, suffer an optimism bias. And it's often very hard. This study showed that even when presented with evidence that would refute their optimism, people still continue to carry that bias. And so I think the human psyche and what we want to believe is a very, very powerful thing that we don't quite understand and may not pay enough attention to as doctors. This is a wonderful paper from Thomas Gill's group. So Thomas Gill is a geriatrician in the US. And this was a study where about 60% were elective surgery, 60% were emergency surgery, and it was every kind of surgery, cardiac, urology, etc. And he divided people into their preoperative functional status, so no disability, mild, moderate, or severe. And then he looked at their functional recovery, so their trajectory of recovery. So you can see that in the no disability group, and I hope the colors are coming out okay, there was about half of them had a really rapid improvement. And then there's kind of like a small group right at the top, that 5% who had some early death. And I would suspect, even though it wasn't teased out in the study, that perhaps these people who are fit and well to start with underwent more aggressive procedures. Whereas then you have down here on the right-hand side, those who start off with severe disability. Most of them, if they have anything, is a partial improvement, but the majority of them have little improvement. So I think this is probably a point, and I'll come to frailty in a second, but really where if you've got someone who's really functionally impaired to start with, doing something to them is probably not going to change their function afterwards. And you're putting them through the risks of a procedure, perhaps without much benefit for them in the end, despite what they may think. And then this is another one, which was Paul Miles. Many of you in the colorectal field will have heard of Paul Miles because he did that aggressive versus restrictive fluid, IV fluids in ERAS patients. And he looked at the WHODAS, which is the World Health Organization Disability Assessment Scale. And what he did was he looked at disability-free survival, and this is at a year, and it's just broken up by the different types of procedures. And one of the points he makes in the paper was that with the orthopedic group, most of their orthopedic patients were trauma, so they're like, oh, this is why disability-free survival for orthopedic patients is so bad. But actually, if you look down at the bottom with the asterisks, the disability-free survival for hips and knees was actually really poor at 53%. Now, it's small numbers, but I just think it's important that we start to think about, well, what we think we're giving patients and what we actually might be giving them, and the outcomes we might be giving them at a year may not marry. So I suppose then, how do we better select people? Because I think this is really, really hard. And I think this is kind of like one of the crux problems that we have in healthcare. So we're really fortunate at Logan Hospital. Our directors of surgery, initially Brian and now Matt, sponsored this project that we did where we screened for geriatric risk factors, and then I did a comprehensive geriatric assessment on those that were identified, or at least that was the plan. We found that 4 out of 5 people we screened had a geriatric risk factor. So it would have essentially meant that I needed to see everyone over 70 coming for an elective procedure, which became impossible. But there are probably some geriatric risk factors that I think are more important than others, and I'll come to those in a second. So these are the ones that I as a geriatrician think of, and I think 2 of them have already been mentioned today, the first being frailty and the second being cognitive impairment. But the other ones you probably don't think much of as a surgeon beyond, oh God, they're on anticoagulation and an antiplatelet, is actually polypharmacy. And data from Ruth Hubbard's study and on the work that we did in Cooperate shows that about 2/3 to 3/4 of people have polypharmacy, and that's 5 or more prescribed medications. Now, I would challenge you to find someone who doesn't have 5 or more prescribed medications, and that's before you get to all of the other stuff that they take on the side. And that really is a problem in older people because of medication interactions. And it also shows that about 75% of people aged 65 have 3 or more chronic conditions. So I think this is where I'm coming to the point of this is beyond the scope of one of us, any one of us to manage. You as a general surgeon, an orthopedic surgeon, a transplant surgeon, there is absolutely no way you can keep on top of all of the medical side of things. And I can tell you as a physician, I can barely keep up with some of the medical things I'm meant to know as well. And the other thing that people don't think about is malnutrition, and frailty and malnutrition can be interlinked, but also obesity, malnutrition is a big problem that we have in our population. And then functional impairment, which has got a lot of overlap with frailty. So this is actually Australian data about the prevalence of dementia. So if you remember very early, I said the biggest increase in surgery is in those 85 and older. You've got 1 in 3 of your patients will have some form of dementia, whether you know about it or not. And in fact, they probably don't even know about it. What's really interesting is this is just the geriatrician nerd bit, probably not something surgeons are so interested in, but we've just described a new proteinopathy. So it's an Alzheimer's mimic dementia. It's a TDP43 proteinopathy, and the syndrome is called late syndrome, and it essentially looks like Alzheimer's disease, and it's probably what causes this big jump in prevalence of dementia in people aged 85 and older. So it's very much a disease of the oldest old. It also shows probably why there'll never be a single treatment for dementia, because it's such a heterogeneous disease, and I don't think we even know half of what we're talking about yet. So if you look at the cognitive impairment in elective surgical patients, now this is not dementia. So when I use the term cognitive impairment, I'm talking about someone took out a screening tool and said that they did or didn't do well on a screening tool, which is very different from the clinical diagnosis of dementia. But about 1 in 4 to 1 in 3 of your patients will have some form of cognitive impairment if you were to go looking for it. And that increase is even higher in the emergency group, but I will put a caveat to this. So the MacA is the Montreal Cognitive Assessment Tool. It's like the MMSE, but on steroids. It's what most of us use because the MMSE is now under copyright, so it's got problems. And I think what most of these studies fail to recognize is that many of these patients have delirium, which is acute brain failure, probably on top of what may be a baseline cognitive impairment. But the last study here, the vascular surgical patient group, so 2/3 of them when screened had impaired cognition as measured by a Montreal Cognitive Assessment Score less than 24, but 90% of them were not known to have pre-existing cognitive impairment. So this is what I'm saying to you. If you're looking after older people, many of them will have cognitive impairment and you probably won't know about it. It's the person who comes into your room and they just constantly look to their wife or their husband or their daughter, and the daughter does all the answering. If you see that, the kind of, Dr. McGowan had a name for it at one stage. I can't remember what it is. Maybe he can't either. Sorry, Brian. But that kind of like reflex look, think about cognition. If someone is not able to give you a history themselves, they probably have some cognitive issues. And why is it important? Well, it causes delirium. Delirium is the patients who are still in your ward 4 weeks down the track after you've done an operation and they won't get up with the physios and they're wasting away. Delirium is associated with much poorer health outcomes in all post-operative cases, and it also presents a higher risk for dementia down the track. It also is a harbinger for other geriatric syndromes being there. If someone's got cognitive impairment, frailty goes with cognitive impairment. So that's why like these things it's so intermeshed. Geriatric medicine is really interesting because it's so complex. And then I think the other thing that we haven't talked about is that it may, and I'm going back even to Rob Franz's point about, you know, the Human Rights Act, if patients don't have the capacity to consent, this is going to be the next thing. Well, you know, you didn't know I had dementia and you consented me for procedure, but I didn't know what I was consenting to. Or I think it's really important. It also, one of the things we see, we've got a gentleman who had a procedure on our hospital recently as an emergency. He had a Hartman's. He can't manage to use his Hartman's. He will never learn to use his stoma because he has no executive functioning and no working memory, and he will never be able to live on his own again. And he now has to go from living independently to living in a nursing home because his brain just isn't working. So these are why it's important in terms of cognitive impairment. Frailty, I'm so pleased to hear both Dr. Frazier and Dr. Jacob talk about frailty. I think frailty to me, so you're either, the way I conceptualize frailty is looking at someone where they were, say, at 70 versus 90, the same person, or you're looking at two 90-year-olds. There's definitely people who are well 90-year-olds, but there is absolutely no escaping the fact that frailty and age are intrinsically linked, and the older you are, the more likely you are to be frail. And as much as I like to say it, and this probably will get me kicked out as a geriatrician, you're a good 90-year-old until you have an emergency laparotomy and the consequences thereof, and suddenly your frailty, the reserve you have in the tank, is very, very quickly shown to not be there. And just very quickly, there's two schools of frailty. As you will see, I wrote a book chapter, and so I'm shamelessly referencing myself because it was so much work. There's two ways of looking at it. So Linda Free put this idea forward in 2001, and her idea is frailty is you know it when you see it. So that's the person who you're kind of looking at them coming in, and they've got the weak handshake, and you know, you've walked into your room and 10 minutes later the person is getting in there and they've taken 4 attempts to get off their chair. And that idea is that they think that frailty causes disability. Whereas Kenneth Rockwood, who's probably one of the best known, his version of frailty is slightly different. His is based on a mathematical model, and Arnold Mitnitzky, who wrote the Frailty Index with him, is actually a mathematician. And they put forward this mathematical modeling that we all accrue deficits as we go through life, and we accrue about 1 to 2 per decade, which, if you kind of think about yourself, probably holds true, unfortunately. And they look at both things like medical comorbidity, function, and cognition, and they put them all together in we call it they count the number of deficits you have. And they kind of have this idea that frailty and disability are intrinsically linked, but one doesn't lead to the other. So they're just kind of one is kind of like, you know, the idea to me, the way I conceptualize, and this is based on Ruth Hubbard's work, you know, a toaster doesn't have much redundancy, but we're more like an airplane. There's lots of redundancy before the airplane falls out of the sky, but sometimes they still do. In humans, you accumulate deficits, and there's only so many deficits you can accumulate before the complex system fails. Most of you will recognise this from Queensland, or if you don't, this is actually part of the Minister's priority. So there's the Minister for Health put forward the Frail Older Persons Collaborative, and this has been the frailty screening tool that has been adopted for Queensland. This is really simple. If you're a surgeon who sees older people, which you all are if you're not paediatric surgeons, you could have a copy of this behind your desk. And just once you start to get used to using it, it actually is pretty intuitive. So if you've got someone, you've walked in back to your room and 10 minutes later this person comes in, they're probably mild to moderately frail already. And as soon as someone's frail, their outcomes are worse. And in fact, there was a study just published in JAMA Surgery this week, which was a big data set, and they looked at people in the US who were frail and undergoing procedures, and even low risk procedures in frail people, and we do a lot of them, are associated with higher morbidity and mortality. So it's really points to a bit of a change in how we need to look after older people. And the prevalence from the work we did at Logan with the Cooperate project was about half of our patients were vulnerable or frail, and that holds with what we find in the literature as well. And these are older people. There are frail younger people, but that's a whole other conversation. And this, again, shamelessly stealing from my own work, this is like a conceptual idea. So Andy Clegg, who's a geriatrician in the UK, kind of put a version of this up a couple of years ago, and this makes sense to me. So we would all like to think we're like the green line, and we all like to think this is our patients. They're up in the green line, everything's going well, they have a procedure, they're sore for a couple of weeks, they're better, everything's fine. But a lot of our patients are here in this red line, where they're already just above the line of independence. Surgery drops them down. And, you know, if you think about patients in your ward 3 weeks, why are they still in? They're still in because they can't get out of bed. They can't go to the toilet. They can't look after themselves. And that's a very predictable outcome from someone who's already barely functioning. So I just want you to think about this rather than and I think that it's together moving forward that we can maybe change how we approach looking after older people. The unfortunate thing about frailty, and there's so many association studies, if someone publishes one more association study showing frailties associated with poor outcomes, I think that's been done ad nauseum. No one has really shown how interventions can change the outcome, and I think that is a really big failure on our part, and I mean ours, the medical community. I think we have a lot of work to do to see, is there anything that we can do to change outcomes for frail people? I think prehab is being pushed and pushed, but the evidence supporting prehabilitation is, I'm yet to be convinced, certainly in older people. And the people that have the worst outcomes are the emergency group, and they don't get any prehab. So we need to kind of figure out how we do this a little bit better. So this is my view on what we should do. I think the term shared decision making is bandied around a bit, but most of us like to think we do it, but we probably don't. But I very much support, I can't remember, I'm sorry, the name of the person at the back. When I'm having discussions with patients, I actually don't particularly ask the family to make a decision, and Matt and I have made many of these discussions together. I think our job as clinicians is to, and as doctors and specialists, is to tell the patients what we think is the right decision and why we think it is, and help support people through the decision that we've made, not say, well, these are the options and here, which would you like? Because, you know, is it the salmon, the chicken, or the beef? It's actually, with my experience and with Dr. Burstow's experience, we believe that surgery is not going to be in your mom's best interest, and we think that the best thing that we can do is help her die a comfortable death with all of the family around. Now, we've had pretty good success in doing it. Are those easy conversations? Absolutely not. They are awful every time. They involve lots of boxes of tissues, but I feel that our job is to make that recommendation, and I think that we can't shy away from it. I also think as surgeons, you need to know what you don't know, and that's what I mean about that cognitive impairment, frailty, interactions. When I started in perioperative medicine, I had no idea about so much stuff, and I still don't. There's so much around surgery, and I'm not even talking about technical, because no one has wanted me in their theatre for about 20 years. With really good reason. You would probably kick me out within about 5 seconds. I would also scratch my face. Every time I used to go into theatre, I'd scratch my face with the mask, and it's like theatre nurses would go nuts. But I think care of older people is really, really complex, and I think that it's only in these shared working environments that we can improve care. And I've learned so much from my surgical colleagues. They've learned from me, and it's the combination of the two of us working together that I think is the way forward for healthcare. I think the challenges for surgeons, as has been alluded to, is how do you balance with complaints and pushy families? And I don't have an answer, because there is no answer and there is no easy answer. But I think offering second opinions, having 2 consultants, and I see very much my job, like none of the surgeons at Logan need to come to me where they've got someone where it's very clear that they need to have an operation. They come to the ones you should involve a physician in, or a geriatrician, or an anaesthetist, or whatever your resource is the people where you're like, I really don't want to do an operation. What do you think? And then having those conversations from there. I also think that the challenge for you as surgeons, certainly in private practice, is how do you find someone who wants to do it? Because the problem for us as geriatricians in private practice is we don't have any procedures. And so from a financial point of view, it's actually not very incentivizing for geriatricians to work privately with surgeons. And so there may be some need to go forward in terms of whether we measure quality outcomes or whether we measure other things or other ways of paying, but that's a whole other kettle of fish. I also think that this is an issue, and like obviously John and I have had these discussions. I think the problem for you as surgeons is that when something goes wrong, even if I'm involved, you still have to answer for it. I think unless we kind of deal with that, and perhaps QASM should include the team that were involved and maybe involve some other questions around inputs of the other teams, so to make the rest of us involved in perioperative medicine accountable as well. The outcomes are reported under your name. There's not even like within the Queensland Health system, you can't have 2 admitting clinicians. It just implodes, it can't handle that. And I think that's also a problem. And And then the follow-up is often done by surgeons. And so you're the ones kind of left carrying the can for years and years. And I think that unless we start to share that around a little bit and share some of the success stories as well as the pain, that's not going to change. So obviously I thought I would finish with, well, why might we have some answers? I think one of the things that I've found working with my colleagues at Logan is that, you know, my patients are all older. I don't look after young people because they're boring. Young people, you can do lots of stuff to them and they still get better. Older people are much more interesting. Their life stories are interesting. Like, we had someone a couple of years ago who had this story about how he ran off with his wife and she now had dementia. And one of the reasons he wanted a particular form of treatment was to be able to go back to the nursing home to be with his wife because he was the only person she still recognized. Those are the bits I find interesting. They're possibly not as interesting to surgeons as they are to geriatricians. We can help you with some of that complex decision making, but it does take us a while to get up to speed with surgical decision making. When I look at kind of how I was when I first started and where I am now, I think my nuanced understanding of perioperative medicine is much better. It still has a long way to go, and I think that it requires a lot of teaching from you to us and vice versa for that to work. And I think one of the other things is geriatricians, we know how to look after people when they're dying. We know how to we can look after people longer term. We're not just in the operating theatre with you like many of your anaesthetic colleagues, which has been a problem, or when they're discharged from the ICU. We'll still be there in 4 weeks' time. We're like a fly, you can't kind of swat us, always hanging around. And so one of the things that I bring is that, you know, for our surgical team, for people who've been in 3 weeks, a lot of the time, they no longer need a surgeon. They need someone to coordinate complex discharge planning, and that's where my role is. And so we've often found that at different points in our patients' time in the hospital, they have different teams more involved than others. I think ideally some of these patients should be primarily under geriatrics, but that's a whole other political landmine. But, you know, I think we have to move forward. So anyway, thought I'd try to be a bit controversial. Some of you may disagree with me, and that's good, but I think the whole point of a talk should be to kind of think a little bit and maybe challenge some of our preconceived ideas about how we do things, because just because we've always done them doesn't mean that's how we should continue to do them.
Thank you very much, Aisling.